I'm happy to be back with you for our second webinar of the year. The series this year is unusual in that we're moving away from the straightforward topics because we know that there are plenty of webinars out there now on on neonatal abstinence syndrome, on fetal alcohol spectrum disorders, and we want to move the chain a bit and talk about some of the issues that just don't get discussed very often. And today's topic, discussing neonatal abstinence or withdrawal versus neurobehavioral deficits in the newborn, came about because I've gotten so many questions about this. One of the most common emails and telephone calls I get is asking what medications should be used to treat an infant whose mother has used, for instance, methamphetamine or alcohol, if the infant is having difficulties in the newborn period. And so I thought that would be an issue that we need to address. Our purpose this year is essentially we're going to talk about things that most folks don't talk about in polite company. And discuss some of the most frequently asked questions that we get coming into our website. One of the issues that I particularly have is some of the use of terminology, and we see this across the field. So this week we're going to be talking about newborn withdrawal or neurobehavioral deficits. And as we present each of these, we'll be looking at both sides of a question because there is quite a bit of controversy. And quite honestly, as we go through this, we'll probably be raising more questions than we have answers for. My philosophy has always been that clinical curiosity is what should drive research. And we're going to ask questions that hopefully will stimulate some of you to look a little more closely at your clinical populations. That being said, what are the key questions we're going to talk about today? The first is, what is true neonatal withdrawal? Is it the same as abstinence? How does neonatal abstinence syndrome differ from neurobehavioral difficulties? What factors affect diagnostic labeling? And is it really that important to have this discussion, to differentiate NAS from neurobehavioral difficulties? Because in the long term, does it really affect the treatment of the newborn? So those are the issues I'm going to try to address today. And as I said, terminology is very important. So I want to talk about some key words that I think we need to be clear on our definitions. And I took these definitions from a variety of resources, including the DSM, from ASAM literature, and tried to pull it all together. Addiction is defined as a state in which an organism engages in a compulsive behavior. The behavior is reinforcing, and there's a loss of control over limiting that behavior. Dependence is a state in which an organism functions normally only in the presence of a specific drug. And when the organism doesn't have access to that drug, then there is a physical disturbance. Abstinence is the practice of restraining oneself from indulging in something. Now, everyone is usually pretty clear on that, but one of the confusing things that's happened is that folks have taken neonatal abstinence syndrome to mean that abstinence is withdrawal. And in fact, withdrawal is a result of abstinence. Withdrawal is the unpleasant physical and mental effects that occur when you stop doing or taking something. And the neurobehavioral, we're going to be looking at it in the newborns in the context of relating the actions of the nervous system with behavior. So those are some of the definitions, and as we have this discussion, we'll be coming back to them. The other thing I want to be clear on, and if I'm insulting anybody by doing something as basic as reviewing the human nervous system, forgive me. But we're going to be looking at all levels of the nervous system today. The two main categories of the nervous system, of course, are the central nervous system, which is made up of the brain and spinal cord. And this is really command center. The peripheral nervous system is made up of the cranial nerves and the spinal nerves. And these are the communication lines between the central nervous system and the rest of the body. Now, the peripheral nervous system has two components. One is sensory, and the other is motor. Now, the sensory division is made up of somatic and visceral sensory nerve fibers that conduct impulses from receptors peripherally to the central nervous system. Whereas the motor division is made up of the motor nerve fibers and conducts impulses away from the central nervous system to the ultimate target, being muscles and glands. The motor division is made up of two components. There's the autonomic nervous system and the somatic nervous system. The somatic nervous system is essentially the voluntary system, and basically is for movement. It conducts impulses from the central nervous system to skeletal muscles. The autonomic nervous system is the involuntary system, and it conducts impulses from the central nervous system to cardiac muscles, smooth muscles, glands. And the autonomic nervous system is made up of two components: the sympathetic division, which is really, as the root word sympathy, that that's the fight or flight system. That's what you use in emergencies. And then there's the parasympathetic system, which conserves energy. It promotes housekeeping. When you're going to sleep at night, the parasympathetic system takes over to help you relax into sleep. Now, the reason I wanted to review this is because many of the issues that we're going to be discussing are issues that are out there in the autonomic nervous system. And you can see what role it plays in the context of the larger functioning nervous system. Let's talk about maternal substances of abuse. And I don't know if you realize it, but before the thalidomide epidemic in the 1940s, it was thought that the placenta serves as a barrier, that a mother could take pretty much anything she wanted to, and the placenta would protect the developing fetus. It was with the thalidomide epidemic that folks began to realize that anything a mother takes actually crosses the placenta, and the placenta should be thought of more as a sieve than a barrier. Substances of abuse, in order to cause changes, to make people want to take these drugs, the substance has to be able to cross from the blood into the brain. That's called the blood-brain barrier. The characteristics of any of the substances of abuse that help them cross into the brain and cause the feelings of excitation, relaxation, whatever the drug does. In order to cross that blood-brain barrier, the substance has to be of a low molecular weight and highly lipid soluble, because the brain is made up of almost all lipid being fat. Now, these same characteristics are what allow any of the drugs of abuse to cross readily across the placenta: low molecular weight and highly lipid soluble. And the thing is, during pregnancy, transmission across the placenta increases with increasing gestational age of the fetus. Why do we get so many questions regarding what's withdrawal and what is neurobehavior? The problems, there are multiple problems to this. First of all, most of the studies are either very small studies or highly selected samples. And obviously, in human research, we can't do the gold standard of a randomized controlled study. We can't line pregnant women up and say, you take heroin and you don't. So what we have to do is use samples of what often are termed high-risk populations to try to find those women who are using during pregnancy. That results in a great difficulty of prospectively collecting measures of substance use. Now, there are several studies now that have been able to accomplish this, but usually the earliest that information is collected is early in the first trimester. And we have to rely on recall as to what the women were using before they ever knew they were pregnant. Human life is complicated with many confounders out there, and we have to rely on our statisticians to help us control for potential confounders and using varying methods and levels of adjustment. These difficulties result in differences in study design and outcome measures. And it's those outcome measures that often get us into trouble, because if someone is studying neonatal abstinence syndrome, they're going to be looking for neonatal abstinence syndrome and not be looking for neurobehavioral changes. So the way that you define your outcome measures is what's going to define the independent measures. That is what you're going to measure to get to your final outcome. If you research the literature also, you find there's a great variance in terminology. And I've done quite a bit of a review of the literature. And in fact, I should mention, we've posted all of the references for this presentation on our website. So all you have to do is go to the website and look for the section called references, and you'll find the references. If you click on that, you'll find the references for this presentation. But if you look through this, you'll see that there's quite a bit of confusion, even in the research level literature, on terminology such as addiction versus dependence, and they're often used interchangeably within a paper. Understanding the difference between abstinence and withdrawal. And in fact, neonatal abstinence syndrome is sometimes termed neonatal discontinuation syndrome, which comes from the adult literature, especially with the research on SSRIs. When adults stop taking their SSRIs, then they do have what I would term neurobehavioral difficulties, and that has been termed NDS, which some people have now converted to newborns. And so some of the literature that, if you review it on that list I've given you, you'll see that some people talk about neonatal discontinuation syndrome, meaning that the drug has been discontinued. Of course, in the human condition, there is polydrug use. And to do a study, for example, of opiate use during pregnancy and neonatal abstinence syndrome, from our own research, we find that 81% of infants whose mothers have gone through who have used opiates and the babies have NAS, 81% of those women also used alcohol during pregnancy. Almost all of them smoke cigarettes, and many use marijuana. So figuring out all the different aspects is difficult. And then when it comes down to it, what we do know about drugs and the physiology and pathophysiology of drugs, all of that work is done with adults. And it doesn't necessarily translate to our understanding of the fetus and the newborn. Because the physiologic effect of these drugs in the fetus is much more complex than in adults. The fetus, of course, has a very immature neurological development, immature neurological processing. There are the pharmacokinetics of the maternal, fetal, and placental interface. And the fetus, for most drugs, has a prolonged half-life as compared to studies that have looked at these issues in adults. So this all just further complicates the issues. Now, with all those caveats in place, let's try to make some sense of all of this. Neonatal abstinence syndrome, in its original definition, was the collection of signs and symptoms that occurred when a newborn is prenatally exposed to opiates and experiences opioid withdrawal. Now, that's very important to remember because neonatal abstinence syndrome, in its original definition, applies only to prenatal opiate exposure. Now, those opiates can be anything from heroin to methadone to prescribed Vicodin, OxyContin, any type of narcotic. But neonatal abstinence syndrome that diagnosis should be used only when the infant suffers opioid withdrawal. The other interesting thing, if you look at the literature, you get a wide variance in the prevalence of neonatal abstinence syndrome. And in fact, among opioid drug-exposed infants, you get estimates of anywhere from 2 to 11 to 55 to 94% of the infants who were exposed go through neonatal abstinence syndrome. So, and if you look at all of the studies, you can see that NAS is defined in a variety of ways. One of the things I want to make clear, which is not always clear in the literature, is that neonatal abstinence syndrome does not represent addiction. It represents dependence. Now, some people may even argue with me about that one, but if you recall the definition of dependence, what we said was that dependence is defined as the physical sequelae, the unpleasant physical sequelae that result from the absence of access to a drug. And so in a sense, neonatal abstinence syndrome represents dependence in the newborn. But importantly, it does not represent addiction. Now, to understand the drugs of abuse, I want to review some basic functioning of the nervous system, especially the catecholamine system. The catecholamines, the primary ones that you've probably heard of, and most people talk about most frequently, are dopamine, serotonin, norepinephrine. There are multiple other catecholamines. Catecholamines are also known as the neurotransmitters. The catecholamine system is responsible for transmitting neurological impulses from one nerve ending, that is the presynaptic junction, to the postsynaptic nerve, the nerve that is on the far end of the synapse. And catecholamines, as the name implies, neurotransmitter, transmit the electrical impulse across the nerve gap. And we're going to focus on dopamine. So the electrical impulse, as indicated by the arrow on your left, is traveling down the nerve pathway. The dopamine receptors pick up the electrical impulse, carry it across the nerve gap, release the electrical impulses, and then the dopamine circulates back to the first nerve ending. That process is called reuptake. And so that's how you regulate your, for example, motor behaviors, is through that dopamine reuptake. Dopamine is part of the regulatory center of the brain, but it's also known as the pleasure center because high levels of dopamine are what cause excitation, what give a drug user the high they experience. And in fact, that dopamine high is why drug users use drugs. Now, in speaking of opiates, This is a graphic that represents the action of opiates. Now, let me orient you. First of all, morphine is the opiate we're going to select, but you could have selected any of them. And those are represented in the green. The yellow is the opiate receptor. Dopamine is represented in blue. Now, this all occurs in the nucleus accumbens, which is part of the limbic system. The opiates in green bind to the opiate receptors, which are represented in yellow. When the opiate receptors are bound, it sends a signal to decrease the amount of GABA that's being released. Now, GABA is gamma aminobutyric acid. GABA's role is to inhibit dopamine release, so that when you want to be calm, when you want to calm down, you're releasing GABA because dopamine, as we said, gives you a high. Dopamine is what gets your heart going. Dopamine acts on smooth muscle, so you get a rapid heartbeat when you have high dopamine levels. GABA inhibits dopamine release, but when a person uses opiates, the opiates bind to the opiate receptors, so then that decreases the GABA release, which sends a signal to release more dopamine. So see how that works? So you're inhibiting the action of GABA, which means you're stimulating dopamine release. And that's the high. Those are the kinds, that's where opiate users get their high from opiates. The exact pathophysiology of neonatal abstinence syndrome has never been understood. All we know is that NAS can be present at birth, depending on when the mother last used her opiates. It usually peaks around 3 to 4 days after birth. The acute phase in general is up to about 6 weeks, but the effects, you can measure neonatal abstinence syndrome effects up to 7 to 8 months. And one of the papers I have listed is the research paper that we documented the information I just gave you. And we defined the acute and the subacute phases of neonatal abstinence syndrome. Now, what does neonatal abstinence syndrome look like? For those of you that want to take a deeper dive into all of this, in the inner circle, the green circle that you see here on this slide, this is what happens when a chronically stimulated opiate receptors don't get a supply of opiates. So this is what's happening in the newborn. At least this is the latest thinking. So the lack of opioids being available to chronically stimulated receptors sets off a chain of events. There is a high level of activation of adenyl cyclase, which increases varying levels at the cellular level of multiple factors, resulting in an increased release of a variety of neurotransmitters. I spoke earlier only of dopamine. But what happens is that this lack of dopamine that is there to be stimulated, because what happens is you get depletion of the dopamine receptors with chronic drug use. So the fetus, we think, suffers from depletion of the dopamine because of all the stimulation during pregnancy, so that when you have low levels of dopamine, you get hyper irritability and anxiety. Acetylcholine increase is what gives you a lot of the autonomic nervous system stimulation, such as diarrhea, vomiting, yawning, sneezing, sweating. At the top, the corticotrophin increases because of increasing levels of stress. And so you get increased stress in the newborn with hyperphagia. Serotonin is decreased, and that's what disturbs the sleep cycles in the infants. And the noradrenaline increase is what produces the hyperthermia, hypertension, tremors, and tachycardia. So you can see that all of these classic symptoms of neonatal abstinence syndrome are grounded in this, at this level of neurotransmitter release and the availability of various neurotransmitters in the newborn infant. Now, one of the confusing things is that there is quite a bit of literature published that talks about withdrawal from non-narcotic drugs. And as I said in the beginning, neonatal abstinence syndrome is grounded in prenatal opiate exposure. But what are some of the other drugs that have been identified as producing behaviors that are consistent with newborn withdrawal? Alcohol produces hyperactivity, crying, irritability, poor sucking, tremors, seizures, poor sleep patterns, hyperphagia, diaphoresis, and the onset can be as early as right at birth. The barbiturates can present at 3 to 4 days after birth, as long as 10 days to 2 weeks after birth, because of the long half-life of barbiturates in the newborn. But once the infant starts going through this behavior, they show irritability, tremors, very sensitive to sound, excessive crying, vasomotor instability. So you get, they can look very pale and blanched, and then very red, hyperemic. Diarrhea, restlessness, increased muscle tone, hyperphagia, vomiting, and disturbed sleep patterns. Now, the SSRIs, there is a behavior described in newborns associated with maternal SSRI, except it's not called neonatal abstinence, it's called neonatal discontinuation syndrome. I think that the authors of those papers tried to get away from implying anything related to what might be interpreted as addiction. So neonatal discontinuation syndrome from SSRIs, in the newborn, there is irritability, constant crying, shivering, increased muscle tone, problems with feeding and sleeping, and they have been shown to have seizures. And finally, diazepam. The behaviors that have been termed withdrawal from diazepam in the newborn include very poor muscle tone and poor suck, problems with temperature regulation, with the temperature going very low, apnea, increased muscle tone, increased reflexes, tremors, vomiting, hyperactivity, and rapid respirations. Now, you look at just these examples, these four substances, as examples of non-narcotic drugs that can cause infant behaviors that are consistent with withdrawal. And you have to ask the question, is this truly withdrawal? Or is it neurobehavioral difficulties? If it's withdrawal, which comes as a result of dependence on a drug, and dependence occurs because the drug is not available, then the question is, should you be giving these infants medication that might help them come down off these drugs? And that's why it's then important to look at the question of all these symptoms that are listed here, how much of this is true withdrawal, And how much is neurobehavior? So what is neurobehavior? Neurobehavior relates to the relationship between the action of the nervous system and behavior. And the way I think about it when I'm working with newborns, it's the way in which a newborn infant interacts with and responds to his environment, whether it be the internal or external environment. Substances that have been associated with neurobehavioral changes include nicotine, alcohol, marijuana, cocaine, methamphetamine, phencyclidine, and opiates. The way I like to think about neurobehavior is from the perspective of information processing. Information processing is the way your brain takes in information and uses it. There are 4 domains of information processing. There's input, that is bringing the information into the brain. Integration, how you assemble that information, you put it together to interpret it. Memory, how you store that information for later use. And finally, output. What behavior, what language, what emotions result from the stimulus that was input. So those are the 4 steps of information processing. Now, this is just a brief review of the brain and its anatomy, and where you particularly need to look is just the major lobes of the brain. There's the frontal lobe, the parietal lobe, the occipital lobe, the cerebellum, and the temporal lobe. And a key area of the frontal lobe is called the prefrontal cortex. The prefrontal cortex is important because that's where your stores of dopamine reside. The important thing to understand is that in the information processing model, input, that is the way information enters the brain, occurs along different pathways. So for instance, visual information, anything you see, enters the eye, travels the entire length of the brain along the optic nerve, and inserts on the occipital lobe, also known as the visual cortex. Auditory information, that is what you hear, enters the ear, travels along the 8th cranial nerve, and inserts on the midline of the brain. And finally, taste, touch, and smell enter the parietal lobe. Now, the job of the brain is to integrate visual, auditory, tactile, olfactory information, to integrate them so that you can make sense of the stimulus, store it as perceptions and memories until you need that information, where the information shoots forward to the prefrontal cortex, where the dopamine receptor system is stimulated to tell you how to respond. Now let's just take a simple example. If you're walking along a sidewalk, you come to a street, you look to see if a car is coming. If you see a car coming, that image enters the eye, travels along the optic nerve, inserts in the occipital lobe, the visual cortex, flash, there's the car. That information then shoots forward to the prefrontal cortex, where dopamine fires off and sends a signal to your legs to stop walking. That's motor regulation. And we could go through any of a number of daily activities and understand them in the perspective within the perspective of information processing and regulatory behaviors. Now, what about what happens when a person uses drugs? Now, here is that same graphic I showed you earlier, but now let's just take for an example methamphetamine. People use methamphetamine to get a high. And how do they get that high? It's methamphetamine causes blasts of excess dopamine across the nerve ending, so that you get the high from this blast of dopamine. Cocaine gives you a high. The pathophysiology is a little different. You get normal amounts of dopamine that cross the nerve gap. As dopamine circulates back, cocaine blocks dopamine reuptake. And so what you get is excess dopamine at the distal nerve. And that's why you get the high. Now, these are just two examples. We could talk about any medication, any drug you want to talk about, illicit drug, and it can be explained through its actions on the dopamine receptors. The problem is with methamphetamine use, tobacco use, cocaine use, you get over time depletion of the dopamine receptors. And so you have less dopamine that's going to be available. Now, what has been shown in adult studies, now I caution you again, these are adult studies, is these are a pair of PET scans. Now, on the left is a 22-year-old young man who had a PET scan. And PET scans are scans in which you inject dye into someone's blood system, and then you can take photographs because the dye is picked up by the dopamine receptors. And so what you see here, we're looking down on the brain, on the left image, and what you see is the bright yellow and red. That is the prefrontal cortex, and the yellow and red are the dopamine receptors. Now, this young man happened to go out and start using cocaine. 1 year later, he had a repeat PET scan. And what you see here is depletion of the dopamine receptors. You can see the yellow and red is absent. Now, again, we cannot do these kinds of studies in humans or in newborns, but what it appears is that newborns who have been exposed prenatally to cocaine, tobacco, methamphetamine, are born with depleted dopamine receptors. And so what you get is a baby who's going to have difficulty with regulation because, again, the dopamine receptors are key to regulatory behaviors. The way most studies have looked at this and studied newborns is through the use of the Brazelton Neonatal Behavioral Assessment Scale. Now, there are 7 primary domains that are studied, but among substance-exposed infants, the 2 key domains that have been described as affected by prenatal substance exposure in the newborn are orientation and state regulation. Orientation is the ability to attend to a specific stimulus. The easiest to understand are the auditory and visual stimuli. So, for example, when we're doing a Brazelton, if an infant is lying on his back at rest and you ring a bell or you speak to the infant will show alerting behaviors and will turn his eyes and perhaps even his head toward that sound. And this is as early as 24 hours after birth. And then if you go to the other side of the infant and do the same thing, he will orient toward your voice. That's auditory orientation. Now, visual orientation is quite similar. You can take a red or yellow ball, hold it about 18 inches in front of the infant, and the infant will attend to that stimulus. Better yet, you can give the infant your face. And a newborn infant, even as early as 24 hours, will briefly orient toward your face. And in fact, will even show some early minimal tracking to the lateral sides. But what this shows is that he's able to attend to your face. Now, that's all in a normal newborn. Infants who have been exposed to many of the substances we've been talking about have difficulty responding in this way. So when you ring the bell or when you speak to the infant, he will show the alerting behaviors, but then won't quite know which way to turn when he's trying to find where the sound is coming from. Or if you give the infant your face, for instance, he might glance but move away very quickly. We call it gaze aversion. And if you keep stimulating him, trying to get him to look at your face, the infant will become very rapidly overstimulated, will show very rapid arousal, and will move through a variety of states of arousal. And that's where we get to state regulation, the ability to regulate states of arousal. Now, in a normal newborn infant, an infant may be quiet and sleeping, may begin to become awake, more alert, may even reach an alert responsive state, and may even escalate to a crying state. But newborn infants have self-soothing behaviors. They'll bring their arms and legs to the midline, may even suck their hand, but they're able to soothe themselves. Babies who have been exposed to many of the substances we've talked about don't have this ability to regulate their state of arousal. And so what we see is babies are quiet and sleeping and suddenly irritable and crying for no real reason, no real anything you can understand overstimulated them. And then they just as quickly move down to a deep sleep again. I call it yo-yo behavior. And what you see is the infant is moving from high states of arousal to deep sleep and back up to high states of arousal again. And so it's that in the early newborn, what you see is this difficulty with regulatory behaviors. What it comes down to is what's the difference between what is called withdrawal and neurobehavioral deficits. And I've tried to outline it here. I've looked at the major systems that we've described that are affected and have lined them up side by side. Now, I've done this by going through the literature. I'm sure if somebody else did this, they might come up with a different chart. And I welcome anybody who wants to take another stab at this to join us in trying to differentiate. But here are the main things that I found in looking at the literature. For neonatal abstinence syndrome, we see neurological difficulties with hypertonia, tremors, hyperreflexia, irritability, a high-pitched cry, and seizures. Newborns not exposed to opiates, but exposed to a variety of the other substances when they have neurobehavioral difficulties might to the naked eye look quite similar. But it's quite interesting in that they can be either hyper or hypotonic. And there are especially some very interesting articles written about infants prenatally exposed to cocaine who can show both hypertonicity while other infants show hypotonicity. Alcohol-exposed infants often show hypotonicity, very poor muscle tone, especially in the midline, truncal hypotonia. You also get facial hypotonia, which interferes with feeding. These babies can be tremulous. They can have hyper or hyporeflexia. They can be just as irritable as the infants with NAS, and some might progress to seizures, though that's very unusual. But in addition, you can pick up the auditory sensitivity with poor orientation, poor visual tracking, and very irregular sleep patterns. So if you look carefully, there is a difference in the neurological effects. Gastrointestinal, you get, as we said earlier, vomiting, diarrhea, poor feeding, dysmature swallowing, and we do see failure to thrive in infants with neonatal abstinence syndrome. We don't see that array of GI effects in babies who have been exposed to other substances. The main difficulty is that we see with some of the infants is difficulty coordinating suck and swallow. And then if you think about the facial hypotonia we spoke of, you add that to the mix. So they do have feeding problems. The only infants, from a clinical perspective, that I have seen with failure to thrive of the non-narcotic exposures are infants with prenatal methamphetamine exposure. And that's mainly due because those infants, quite often, rather than being the hyper irritable infant that you expect, those infants often are very hypoaroused. They go into very deep sleep. It seems like they're so irritable that the only way they can protect themselves is to push themselves down into a deep sleep. So they don't awaken for feedings. They feed very slowly when they do feed. So I have seen failure to thrive fairly often, not always, with infants prenatally exposed to methamphetamines. We don't see much in the way of tachypnea or apnea with infants exposed prenatally to non-narcotic substances. And we certainly don't see the autonomic nervous system difficulties when the infants are exposed to non-narcotic substances. Those are fairly well limited to the infants with NAS. Yawning, nasal stuffiness and sneezing, sweating, low-grade fever, mottling of the skin. Grossly, these babies are going to look very similar. But then if you really try to differentiate NAS and neurobehavior, I think you'll be able to do it. And it raises the question in my mind that if we went back and looked at the infants that have been listed as having behavior similar to withdrawal. I remember alcohol, SSRIs, diazepam, we listed there. Do those infants truly have a withdrawal syndrome, or is it neurobehavior? This is some research waiting to happen. In either case, whether it's NAS or neurobehavioral difficulties, the management of the infant is going to be similar. It's going to be supportive with swaddling, a pacifier, low lighting, oscillating cribs, avoidance of abrupt changes, and frequent small feedings. Those are the general supportive actions that caregivers can take. The only infants that have been shown to benefit from pharmacologic treatment are the infants with neonatal abstinence syndrome. Although there is a lot of speculation in the literature and some researchers have looked at this issue, the only infants at this point that should be treated with medication would be infants who were prenatally exposed to opiates and have neonatal abstinence syndrome. Now, why does this matter? Because there's a lot of inaccuracy in what is being reported. We get a lot of misdiagnosis and misdiagnoses. And when we do prevalence studies of neonatal abstinence syndrome, these studies are very important, but they're relying on diagnoses made clinically. And one has to ask how many of those infants actually were not suffering NAS, but were suffering from neurobehavioral deficits, and how many of these infants are being missed. And one of the issues that I've seen for many years now is the racial and social class bias that can be brought into the equation. We published a study in New England Journal of Medicine back in 1990 that showed that physicians selectively pick out women for drug testing at the time of delivery based on race and social class issues rather than actual presentation of the infant. We did a follow-up study with 20 hospitals around the nation and we got IRB approval and collected maternal and newborn hospital charts for all newborns in those 20 hospitals that had been admitted to the neonatal ICU. And what we found when we selected out only all the women who had documented opiate use during pregnancy, when their infants were admitted to the NICU, at the time of discharge, even though looking at the charts, the infants had exactly similar clinical presentations, and all of their mothers had used, it was documented, had used opiates. If the infants were African American and on Medicaid, their discharge diagnosis was neonatal abstinence syndrome. If the infants, same clinical presentation, but the infants were white and had private insurance, they were given a diagnosis of seizure disorder. Now, that study was done almost 30 years ago. I don't know how that would hold up now, but we do know that most studies are being done in lower socioeconomic public hospital populations. And so you get this bias built in to anything you're trying to do. Now, there have been some recent studies on prevalence of NAS that have tried to get past that and have enrolled numerous hospitals of differing social classes, and the populations they serve come from a variety of races. But I think this is an issue that we still have to deal with. The other problem that I see quite frequently is that there is inappropriate use of the neonatal abstinence syndrome scoring tool. Most commonly used is the Finnegan, which I've spoken and done webinars on NAS scoring in the past. But suffice it to say, the NAS scoring instrument, the Finnegan, was not designed for non-opiate exposed infants and really has no role in clinically evaluating infants who were not exposed to opiates. Because if you recall, many of the neurobehavioral difficulties would score quite high on the NAS scoring tool, which would lead to inappropriate interventions and treatment. So I've had cases brought to me where infants with non-opiate exposure with neurobehavioral difficulties were treated with medications such as methadone or morphine because of their neurobehavioral difficulties. All we're doing in those cases is sedating the infant and shutting him off from interactions with his environment and opportunities for neonatal learning. And so we have to be very careful, and that's why these issues are so important. From a policy perspective, we have a long way to go. What are the 5 steps in a policy approach? And this is developed based on a lot of the work that's come out of SAMHSA. But the first step is we have to have public awareness for both professionals and the public on the effects of substance use during pregnancy. And as you know, I've given webinars on marijuana use and shown and talked about the attitudes and knowledge about marijuana. That's a whole other topic. But we're seeing more and more the rates of marijuana use during pregnancy are skyrocketing. So we need both public and professional education. We need universal screening and, when necessary, assessment and brief intervention within the prenatal care sites. And many of you on this webinar know that we work with you directly, and so we're screening in physicians' offices, at hospitals, prenatal care sites across counties and states. And it's not urine toxicologies. We're not doing urine toxicologies. We're doing something better. We're talking to our patients using a validated screening instrument. If the instrument is positive, then we enhance the prenatal services the woman is receiving, and we identify the infant at birth whose mother had a positive screen, so that we can then, at the time of delivery, identify the infant and ensure his safety and respond to his needs, and at the same time respond to the parents' needs and bring the systems that serve infants and parents together in order that the entire family is served. Now, one of the issues we will be talking about in a future webinar in this series is CAPTA, the Child Abuse Prevention Treatment Act, and how it has been ignored. And the presentation will be based on a study that's in press now. It's being published, but we did a study in Iowa of physician and judicial knowledge of the requirements of CAPTA, the Child Abuse Prevention Treatment Act, when it came to reporting infants affected by prenatal substance exposure. So as I said, we have a long way to go. What are the challenges that we face? Preconceptionally, as I said, the public and professionals are not aware of substance use effects on pregnancy and the newborn. During the pregnancy period, there are very few systems that have a complete approach to SBIRT, screening, brief intervention, referral, and treatment. There quite often is a failure to link a pregnant woman who's getting prenatal care and getting substance abuse treatment, to link those two systems. And there's no clear guideline for medication-assisted treatment during pregnancy. For newborns, there's inconsistency and poor quality control in the use of the NAS scoring tool. It's being applied inappropriately to infants that were not exposed to opiates. Even when using it with infants exposed to opiates, you get poor inter-rater reliability. There is inadequate training, and studies have shown bias within administrators, again based on the race and social class of the infant. And finally, there's a lack of a consistent evidence-based approach to the treatment of NAS, much less neonatal neurobehavioral deficits within hospital systems.